And moving on to the next part of presentation today, the college lecture, which is supported by Sidus of Sunshine Pharmaceuticals. Today we have the topic, management of upper GI bleeding. What do guidelines say? By Dr. N.P. Dinamitra, the consultant in gastroenterology and hepatology, District General Hospital, Polonnaruwa, to present to us. Dr. Dinamitra is a MBBS Peradeniya, MD Colombo, MRCP UK and MRCPE. In addition, he has been awarded Medals of President's Research Award for the year 2015 and Health Service Excellence Award for 2009. So over to you, Dr. Dinamitra, to enlighten on the GI bleeding.
Thank you very much, sir. Good afternoon, everyone. I'm Dr. Dinamitra, as mentioned, consultant gastroenterologist from DGH Polonnaruwa. I would like to express my gratitude to the President and the Council of CCP for granting me this opportunity to speak today. I'm honored to be here to share my knowledge and experience with all of you. I hope that my insights will be helpful in advancing our understanding of upper GI bleeding and improving patient care. Thank you again for the opportunity to speak. Ladies and gentlemen, before we begin, I would like to inform you that there has been a slight change in the topic for today's talk. Covering upper GI bleeding in its entirety within 30 minutes is a difficult task. Hence, I'll be focusing on the acute non-variceal GI bleeding and its management. It is important to note that the management of variceal bleeding is relatively straightforward. So if that is what you are hoping to learn today, I apologize in advance as it may not be very useful for you. Sorry for that. So this is a change topic, the acute upper GI bleeding. So I'll be discussing the managing acute peptic ulcer bleeding. What do guidelines recommend? It's important to note that GI bleeding can be a serious condition and should be promptly evaluated and treated by medical professionals. I would like to start stating that I have no conflicts of interest. Moving forward, I would like to emphasize that my talk is based on these two guidelines. This is like the foundation for most of the guidelines in the world, what we are using today. The definition of the upper GI bleeding is defined bleeding that occurs from the upper esophagus up to the duodenum at the ligament of Treitz. It's not very important when it comes to the clinical setup, whether it is like proximal to the ligament of Treitz or not, is not very important. We look at the epidemiology of gastrointestinal bleeding. The gastrointestinal bleeding is a common condition with like 100 per 100,000 per year experiencing some type of acute upper GI bleeding. Males have slightly more risk of getting GI bleeding, but the risk is same if you are more than 60 years of age. Mortality rates are also similar in both sexes, and peptic ulcer bleeding is the most common type of GI bleeding. That is why I'm discussing more peptic ulcer bleeding and its management today. Just wanted to share some interesting studies. Out of 156, sorry for the small letters, 156 patients, 6 had upper GI bleeding. So you know, out of 156 who had upper GI bleeding, only 6 had variceal bleeding. So that is the most commonest is peptic ulcer bleeding. The most commonest drugs are like NSAIDs, low-dose aspirin, warfarin, and SSRIs. This is one of our studies published by my trainer, my mentor, Dr. N.M. Navaratna in Ceylon Medical Journal in 2010. But this shows that variceal bleeding is more common in our population. I don't think that the sample is really representative of our normal population. One thing, because like there were not very many places at that time to do endoscopic band ligation, maybe like a lot of patients would have like transferred to the NHS, so that must be the reason. So the next, I'll talk about the case that I have come across. That is 78-year-old male patient with coronary artery disease with 2 stents put in place, like it was done in about 7 years ago, with a background history of hypertension and hypercholesterolemia, on aspirin 75 mg daily, coming in with 3 episodes of melena for the past 24 hours, with a heart rate of 107, blood pressure of 99/62. And his hemoglobin dropped from 14.1 to 9.1 over a period of 24 hours. He had the baseline hemoglobin with him. So in this case, like this is what we are going to discuss in next 20 or 25 minutes. So patient is on aspirin with high cardiovascular risk factors, elderly male, coming with significant GI bleeding. So we need to decide whether we are going to stop aspirin, or are we going to reverse the effect of aspirin? Or are we going to start him on PPI? Then how much? What is the dose? Whether intravenous, infusion, or intermittent doses, or whether we need to keep the patient in, or whether we need to keep the patient in an ICU setup, or if you are going to do an endoscopy, when are we going to plan the endoscopy? If you stop aspirin, when are we going to restart it? For how long we are going to keep him off from aspirin? So these questions need to be answered. I'm trying to like answer those questions during the next 20 to 25 minutes. So my approach, some of the slides I like borrowed from Prof. Ian Gralnack, who is a General Secretary of ESG. So he kindly submitted some of the slides for my presentations today. So my approach is a pre-endoscopic management and the endoscopic management and post-endoscopic management. The endoscopic management may be a bit more technical for you all. Please bear with me. Some of you can be like endoscopic in like next, like coming years. Pre-endoscopic management. So hemodynamic resuscitation is by far the most important one. Without resuscitation, you can't do anything else. And then we'll talk about the restrictive blood transfusion and what is meant by restrictive blood transfusion. That means, in simple terms, if you give lesser blood, that is more beneficial. If you give more blood, it can be more harmful. And we need to risk stratify and see whether we can, like once we see the patient, whether we can discharge the patient, or whether we have to keep the patient in and do the endoscopy, or we can manage him as an outpatient. And the place of IV PPI, the doses, the durations, I'll talk about them, and the benefits. And antithrombotic management, I can see the neurologist, trainees, budding neurologists in the crowd. And the people who are on antithrombotic management, what are we going to do with those medications if they are coming in with like significant GI bleeding? And the pro-motility agent, what is meant by pro-motility? If somebody coming with GI bleeding, there can be, like you may expect, blood in the stomach, on the upper GI tract. You have to like push them into the small bowel to have a like good visualization of the stomach for your treatment. So that is what is meant by pro-motility agent. And then we'll talk about the timing of the endoscopy. So hemodynamic resuscitation, the safe airway, and the venous access to wide bore cannula, about like at least 16 to 18 gauge cannulas. It's better to have cannulas in cubital fossa. And central line if necessary. It's not, you don't have to have central line in each and every patient. 2 wide bore cannula in the cubital fossa would be enough. And you have to restore the hemodynamic stability before embarking on anything. And if you want to give fluid, what are we going to do? Whether crystalloid or colloids? There is no like robust evidence to suppose, like suggest one is better than the other over crystalloid over colloid. But crystalloid is better. If a patient is hemodynamically unstable, you can give IV normal saline, 500 ml over 15 minutes. That works. Some of the guidelines states that you better give resuscitate patient with crystalloids. And the restrictive blood transfusion, what is meant by restrictive blood transfusion, if your patient is bleeding, coming with upper GI bleeding, if the hemoglobin level is less than 7 or 8, you better transfuse. If the hemoglobin level is 10, like more than 8, you don't have to transfuse at that point. Unless the patient has severe GI bleeding, like you have like upper GI bleeding, coming hematochezia, and patient is have compromised cardiovascular system. You break the rule in patients who are having massive bleeding and cardiovascular compromised patient. Like in our patient, the 72-year-old coronary artery disease, 2 stents, coming with Marina, HP dropped from 14 to 9, with heart rate of 107, blood pressure of 99. So you may break the rule there. But the restrictive transfusion is better or beneficial to lower all-cause mortality and lower rebleeding rates. These are the evidence for that. So this is the same thing in a different slide. Current recommendation is hemoglobin 7 or 8 gram. Why this 7 and 8? Because original research done with less than 7 gram. Then they have done another research, their threshold was 8. And equally like beneficial. That is why the 7 and 8 figure is there. If the patient is have vascular diseases or massive bleeding, your threshold is about 9 gram. The proton pump inhibitors, you know, like GI bleeding, synonymous is you start IV PPI, IV omeprazole. So what are the evidence? Pre-endoscopic PPI in upper GI bleeding, a Cochrane meta-analysis, 6 randomized controlled trials. It will reduce the high HRS is like high risk stigmata of the endoscopy, plus it will reduce the need for endotherapy. But when it comes to mortality, rebleeding, and surgery, it's not statistically significant. So pre-endoscopic PPI should be given to downstage the endoscopic stigmata of bleeding, reduce the need for endoscopic hemostasis. But if you cannot find IV PPI, it is the scenario now in the country. So don't like delay or replace it with endoscopy. Don't wait to get the PPI to go for the endoscopy. What is the evidence for platelet transfusion in upper GI bleeding? This guideline does not recommend transfusion for patients with acute non-variceal upper GI bleeding who are on antiplatelet drugs. Tranexamic acid, the same. They does not recommend the use of tranexamic acid in patients with acute non-variceal upper GI hemorrhage. So like good evidence to say they have done like with tranexamic, without tranexamic, coming with upper GI bleeding. The people like tranexamic arm and the non-tranexamic arm did not have any difference when it comes to like the outcome of the upper GI bleeding, but they had more thrombotic complication in the tranexamic arm. Octreotide, there's no place in non-variceal upper GI bleeding. Please find me non-variceal. It's not. I'm not talking about the variceal upper GI bleeding. So pro-motility agent. Why? A patient with suspected blood in the stomach or ongoing bleeding, we need to push those blood into the small bowel for us to visualize it clearly to plan our treatment. So what are we going to give? They give erythromycin 250 mg IV in 60 to 90 minutes prior to the endoscopy. So contraindication, as you all know, the macrolide allergy or the prolonged QT interval. So in a patient with upper GI bleeding, it's better to have an ECG done. Otherwise, you may miss the prolonged QT interval. Unfortunately, we don't have IV erythromycin available in the country. Giving oral erythromycin, I don't think there is evidence. I don't think much change giving oral erythromycin. What I do in my practice, I ask them to give like Maxilon 10 mg about half an hour before. I don't know whether it works or not. Like that is what I'm doing. For that, there's no good evidence. So I talked about like risk stratification in GI bleeders, like peptic ulcer bleeders. So how are we going to risk stratify? There are lots of scoring systems available, but out of those, the Glasgow dashboard score is the best. It has the good sensitivity, like it's a pre-endoscopic risk stratification. If the score is 0, you don't have to worry. You can discharge. You can manage the patient as an outpatient. The score is 1 or above, you have to do the endoscopy, plus you have to manage the patient as an inward patient. It has like few figures like blood urea level, hemoglobin, like men and women different, systolic blood pressure value, then other parameters like pulse, melena, presentation with syncope, hepatic disease, cardiac disease. So there is only 2 investigation findings here, like hemoglobin level and blood urea level. Everything else is history or examination. So if you have like one of those positive, then you need to keep the patient in and treat. Don't worry about that. If you don't have labs, like lab tests, don't worry, like you have other tests so that you can stratify without those things. Timing of the endoscopy. Early endoscopy, that is early means within 24 hours. It's not urgent or it's not very urgent. Within 24 hours of the patient presentation, recommended for most patients with acute upper GI bleeding. But it should be done after hemodynamic resuscitation. This is by far the most important, hemodynamic resuscitation. Otherwise, we all get together and killing a patient. No good evidence for immediate endoscopy, like doing the endoscopy within 6 hours of the presentation, there's no good evidence. But in ongoing unstable hemodynamics with the hematemesis require more urgent endoscopy, that is within less than 12 hours. So endoscopic management. So this will be like, as I told you all, this will be like more technical, me being a gastroenterologist, endoscopist. So like, this is very close to my heart. So I'll talk more about this now. And I can see the endoscopist gastroenterologist in the audience. So endoscopic management in like peptic ulcer disease, we can't manage them without talking about this Forest classification. So this is Forest classification we use to like endoscopically categorize the patient, whether they have like active bleeding, the massive bleeding, or they have recent evidence of bleeding, or they have like non-bleeding ulcers. The next slide will explain it more clearly. So this is the Forest classification, like on your left-hand side your screen. The acute hemorrhage is Forest 1A and 1B. The signs of recent bleeding like 2A, 2B, and 2C. And the lesion without active bleeding is Forest 3. So sometimes you may see endoscopy report stating that patient had Forest 3, so you continue PPI and you can restart your antiplatelet or something like that. So like this is what we are mentioning, the Forest classification. These are our tools to like tackle GI bleeding. This is the blue color one is a needle where we give like adrenaline injection, 1 in 10,000. The middle one is like gold color, is like gold probe, which is like actual gold. We use it for like thermal therapy. The like things with like ABC naming is those are hemoclips. And the lower down, the other side just below the needle is the forceps, where we can like catch the artery and cauterize. And the middle one like a shotgun or a weapon, the pistol is like chemo spray, where we spray a kind of a powder to tackle the bleeding. The next one is like cap mounted clip, or you call OVSCO, like over the scope clips. These all of them are available in Sri Lanka, and most of the time even in my center in Polonnaruwa we have all of them. So ulcers with high risk endoscopic stigmata should receive endoscopic therapy. What are those high risk stigmata? Like Forest 1A, 1B. If you have spurting vessels or oozing vessel, that is 1A and 1B. Or if you have like non-bleeding visible vessel, that is Forest 2A. You need to treat them. Otherwise, their rebleeding risk is very high. You can't leave them alone. If you do not have like facilities to treat them, you cannot put them back on their like antithrombotic medicine. So this is bleeding risk is very high. Without them, also risk is high. If you put them on those treatment like platelet or warfarin, the risk is really very high. So sorry for the crowded slide. So if you have like high risk stigmata, you have to have endoscopic hemostasis. What we do is like we inject adrenaline around the lesion, and then we like do the thermal therapy. Like we can have contact thermal or non-contact thermal, where we can burn the area to like reduce the bleeding, or we can put a clip. There are enough clips available. It can be like over the scope or through the scope clips. So it's a bit more technical, and the endoscopic may understand this. So this is the, like for a classification, rebleeding risk. If you are like 1A, the about rebleeding risk is 80 to 90, oozing vessels 10 to 30, non-bleeding visible vessels 50 to 60, adherent clot is 20 to 35, but 2C and 3, like black hematine ulcer base, their bleeding risk is not very high. So if you have like forest 1A, 1B ulcer, like spiriting or oozing ulcer, you give direct epinephrine, that is 1 in 10,000, injects for 4 quadrant around the bleeding area, about 1 to 2 milliliter per injections. It has a tamponade effect plus vasoconstriction. And then you use the gold probe, which I showed you earlier, the gold one, the bipolar contact thermal coagulation probe. Better to use these are for like endoscopies. The 10 French one, so that you can have like better effect, like tamponade effect. The setting is about 12 to 15 watts with the tamponade for about 8 to 10 seconds, and firm pressure on bleeding size. That kind of like that wells the particular bleeding vessel. And then we can use the mechanical things like through the scope or over the scope clips. Look at this. This is not running in this my computer, but in your one, it's like spurting vessel, like forest 1A. What we are doing is we are trying to like cauterize using the like contact thermal therapy to like reduce the bleeding. So that is how we treat. Like this is also another video of 2A lesions. You have like non-bleeding visible vessel. Like hidden inside the ulcer. That hole is the pylorus. That the hole that you can see is the pylorus. So this is also for the endoscopists or the gastroenterologists, my surgical colleagues, and the future endoscopists who are in the audience. If you have like 2B lesions, like what to do with the forest 2B? That is 2B is like you have an ulcer with the adherent clot. Are we going to disturb the clot or just leave it alone? So there is no proper guidance to what to do, but this is my approach. So it's better to remove the clot and try hemostasis. Like once you remove the clot, you may see like there's nothing much to treat, then you just leave it alone. If you have like once you remove the clot, you can have like visible vessel, the bleeding or the oozing, then you treat. So I prefer you to like go if the patient is older one, inward patient, comorbidities, just to disturb the clot, remove it, wash it, and see whether bleeding risk is high, then you treat it. This is again for the endoscopist. The epinephrine alone is not adequate. Like you may have like very temporary effect if you inject adrenaline into the lesion, but the rebleeding risk is high. If you have a patient in your ward, in your setup, who had a like endotherapy only adrenaline injection given, that patient rebleeding risk is very high. Patient can bleed again. So the patient who had like high risk stigmata with only treated with adrenaline in your ward, starting them on warfarin or antiplatelet may be harmful. So that is why I put this slide. So please read your report. If we have done something like that, if you have like thermal therapy and adrenaline, all right. If you have adrenaline and clipping, all right. Clipping alone is all right. Thermal therapy alone is all right. These are the low risk stigmata like 2C and 3 lesions. You don't have to do anything. You just give oral PPI. You can restart. The bleeding risk is pre-bleeding risk is less, so you can start them on the antithrombotic treatment. The post-endoscopic management, like, is more relevant to this audience. So high dose IV PPI. What is meant by high dose? Equal or more than 80 milligram for more than 3 days is high dose PPI. For 72 hours IV. How are you going to give? You can give like, this is like post endoscopy. So by that time, we have given already start dose of 80 milligram or something, 80 milligram of IV PPI. Then you can give like 8 milligram per hour infusion, or you can give like intermittent doses like 40 BD or 80 BD, at least for 3 days after endotherapy. And if somebody who had like endotherapy for bleeding and somebody who had this high dose PPI for 72 hours, you need to follow them up with 40 milligram BD, 14 days of PPI. So you treat them, start dose, then your infusion or like intermittent dose followed by 14 days of PPI. And you can initiate clear fluid after the endoscopy. Usually we like after the report we mentioned that you can after 2 hours you may start the patient on clear fluid. And you have to test and treat for H. pylori during the index endoscopy. And antithrombotic management, we'll talk about it in subsequent slides. And routine second look endoscopy is not recommended unless they have rectal bleeding. If we fail to treat endoscopically, then we may have to ask our radiology colleagues to help to come and have this embolization, like find the bleeder and embolize. It's not easy in our setup. If we all fail, then surgical colleagues can help us. So antithrombotic management, the aspirin and clopidogrel. Problem with the people who are on aspirin and clopid or antithrombotic, we have to measure the risk and benefit. So they have one end, they have bleeding, the other end, they have thrombotic risk. We have to like weigh the risk and benefit and then decide what to do, what is the best management. These are the like characteristic of major GI bleeding. If they have like vomiting of blood, melena, sudden rush of hemoglobin less than 6, require transfusion of more than 4 units, bleeding continue for at least last 3 days, and significant rebleeding in 1 week after treatment, and high risk stigmata on index endoscopy. These are the patients who are at high thrombotic events, like patient with AF with these features, high chats, prosthetic valve, rheumatic heart disease, patient with valvular heart disease if they have like metallic valve, and with a recent TIA, patient with venous thromboembolism, like thromboembolism in recent 3 months, and severe thrombophilia like protein CES deficiencies. Patient with coronary artery disease if they have like drug guillotine stent within 12 months or the bare metal within 1 month, they have like high risk of thrombosis. These are the like difficult patients to like tackle. These are chat vast. So if the patient is on low dose aspirin for primary cardiovascular prophylaxis, you withhold the patient the aspirin at presentation, and you can resume low dose aspirin if once the upper GI bleeding is resolved. If clinically indicated, you have like if it's primary prophylaxis, you need to like see whether that indication is still there. If it is there, you can continue after treating the GI. Patient on low dose aspirin for secondary prophylaxis, again low dose aspirin should be stopped. And you can resume the low dose aspirin during the endoscopy. If you find the patient has during the endoscopy, their pre-bleeding risk is low, like 2C or 3 for S3, you can restart. If the bleeding risk is high, then it's better treat the patient and try to start the aspirin within 72 hours. If you fail to start them on aspirin at least within 3 to 7 days of like index bleeding, their mortality from cardiovascular risk factor is high, 30-day mortality is high. So they will die of like heart attack or something. If you do not restart them, their aspirin within 3 to 7 days. It's better try to start them within 3 days. This is like same thing in a different slides. I put this one because I know that now you get a screenshots or a picture during a presentation. So if you want to take this, I'm sorry that this is the screenshot that I have taken, not like in good quality. So the patient on dual antiplatelet therapy coming with GI bleeding, you continue low dose aspirin, you withhold the clopid or ticagrelor or whatever the other one, and then once you treat, you like stop them for about like 1 to 7 days. Once you treat, you try to start them within 1 to 7 days. The same thing for you to get the screenshots, the virtual audience and the others. Right. This is there in the like the same thing, like coming with GI bleeding, low risk bleeding, you continue without interruption. If they have high risk bleeding, you continue aspirin, hold the second one, and you restart them in 3 to 5 days time. And these, like when you have patients like this, you may have to consult your colleagues from neurology department or the cardiology department to like get their opinion and just reassess, have a discussion. This is the people who are on warfarin. Like you have to withhold if they're coming with GI bleeding and do the endoscopy, high risk, no high risk stigmata, plus INR is less than 2.5, you may restart. Otherwise, if patient coming with high risk bleeding, you may have to like reverse the effect with like vitamin K or prothrombin complex concentration or FFP. And after like reversal of event, the bleeding or treating the bleeding, then you can resume within like 3 to 7 days. But in this case, these are very tricky. Coming in the metallic valve, diametric stent within 1 month, coming in GI is very tricky. You may have to like give them like unfractionated heparin sometime. So get your cardiologist opinion or a neurologist opinion. What about the direct acting latest oral anticoagulants? Low risk, whoever who comes with like GIB, you stop it at that point, perform the endoscopy, and low risk, then you can restart. If high risk bleeding, then if you have antidote, you give antidote and reverse the effect. If they have like life-threatening bleeding, otherwise you can restart once you treat the patients. This is like kind of a hot topic, like patient is on clopidogrel, you can't give omeprazole and esomeprazole. Where did that come? So it came from this, like clopidogrel being a prodrug, it needs cytochrome P450 for its activation to have the active metabolite. So omeprazole and esomeprazole is competing with this one, so that like you have a competition, omeprazole, esomeprazole, clopidogrel trying to be very active inside the body. Then like because of that, theoretically, like in pharmacokinetic sense, you have like reduced effect of clopidogrel, this product, or you can have like less active form of the clopidogrel. So that is the scenario, but that is proven in the lab. But when it comes to the real clinical setups, there is no statistical significant difference. Plus, you don't have to give esomeprazole or omeprazole. You can have other drugs like rabiprazole or pantoprazole. You can start them on this one if you are worried about it. PPI and aspirin, do they have any effect interaction? Yes. Aspirin is best absorbed in acidic pH. If you give PPI, if you make in the pH, higher pH in the stomach, may not get absorbed properly. But when it comes to the clinical setup, there is no significant data to suggest for like PPI or recommend not to give aspirin and PPI together. So this is the guidelines. Guidelines vary internationally, recommending the concurrent use of PPI and dual antiplatelet therapy. Like ACCF, ACG, AHA, they recommend that only patient on dual antiplatelet therapy with increased risk, better to have PPI. Other guidelines, they ask like blanket term, like if they are on dual antiplatelet, give them gastroprotection with PPI. This is like the clinical, sorry. This is the like setup in my unit. So this is me. There somebody is holding the blood pack, the patient is bleeding. My few helpers like holding the patient, and somebody is looking at the monitor here. So this is our setup. So this is just to summarize what I've been talking to you all. Sorry for the crowded slide. So I'll just read. Endoscopic therapy should be performed for ulcers with active bleeding or a non-bleeding visible vessel. High-dose proton pump inhibitors like PPI therapy should be given continuously or intermittently. It can be intravenously or orally for 3 days after successful endoscopic therapy. And you can like give another 14 days after this. Early risk stratification should be performed in the emergency department, and patients with low risk, vascular score 0, should be discharged from outpatient follow-up. Blood transfusion should be restrictive, that is only for patients with hemoglobin levels less than equal or less than 7 grams per deciliter, unless they have vascular risk factor and massive bleeding. Erythromycin infusion should be given before endoscopy. We don't have it in the country, you can give metoclopramide. Endoscopy should occur within 24 hours hospitalization. I think most of the hospitals, the bigger hospitals, have that access. Endoscopic treatment should be undertaken for high-risk ulcers, and epinephrine injection should not be used alone, only in combination in another hemostatic modality. And twice daily oral PPI therapy should be continued for 2 weeks after index endoscopy and parenteral PPI. If you give parenteral PPI or high-dose endoscopy, high-dose PPI, you need to give 14 days of PPI. If you need like more information, so we have variceal bleeding guideline published by SLST, Sri Lanka Society of Gastroenterology. It's available. And like we have about like 8 Sri Lanka gastroenterology newsletters. So we have like some article about the GI bleeding. So you can have like free access. And would like to thank CCP for giving me this opportunity, plus Dr. Hasita Vijayavanta for pushing me to do the lecture. And more than that, I would like to thank these 2 gentlemen, Dr. N.M. my trainer, mentor, who trained me to this amazing world of endoscopy and endotherapy. And Dr. Sivan Sudan, Jaffna, my trainer at Jaffna, when I was a registrar, for introducing me to the field of endoscopy. I would like to thank them for their job. And thank you very much. If you have any question, I'm happy to answer.
Thank you, Dr. Dinamitra, for that excellent presentation. Yes, it's open for questions if there are any. Can we have the mic, please?
Thank you, Dinamitra. So when you start PPI, so when you ask some PPI, then now the infusion or
Individual.
any difference between infusion or
There is no statistically significant difference.
is there a difference in the treatment of duodenal ulcer versus gastric cancer with the PPI?
No, as far as I don't know.
The thing is, you said when you decide on endoscopy, you said majority will get endoscopy. and some may not get an endoscopy.
Yeah.
So who will not get an endoscopy? Suppose API and you decide that it needs an endoscopy.
If your stratification like that score, if you put that or last score, if it is more than one, you have to have the endoscopy within 24 hours according to the guideline. But in practical sense, you may not. Better to have an endoscopy. The other thing for you to decide if they are like within 24 hours, their hemoglobin drop is not more than 2 grams, you can wait. Suppose they are like the current hemoglobin should be more than 6. Like this is like against the guideline in practical sense, because most of the endoscopes are out of order in the country. I think we have about like 5% working endoscopy all over the country. We go no endoscopy for the last 3 years. And Candy has only one upper GI score. That is a situation. So I think we have to have a bit more stratification one for us in current situation.
You keep stress answers as same as.
Yes. Whatever the answer, yes, we treat the same way.
Yes, Dr. Raghunath.
I lost. Why do I mean promising before endoscopy?
Because the pro-motility that will increase the gastric motility, so that will push the blood in the stomach into the smaller, so that we can see very clearly.
The oral.
No, doesn't.
There's a question from virtual audience. Is there any target hemoglobin that you need to reach when you resuscitate?
Yes. Like if you have like more than like if your target level is restrictive one, if you can come up to at least 7 grams in acute tuberculosis, it's enough. But in vascular compromised patient, having 9 grams of hemoglobin would be enough in acute setup.
Yes.
Talk about the restrict. So what is the problem if you over transfuse? If you give more transfusion,
The rebleeding risk is high, sir.
Body with blood or even having just a diagnosed gastric ulcer, giving a NSA, lifelong no, or is there any recommendation on that?
This is difficult question, but it depends on the indications. Like, I think you can give indefinite PPI with antiplatelet if they are having like bleeding or high risk bleeding ulcer. That is what we do, because we can't stop PPI for forever, or we can't stop NSAIDs or the antiplatelet forever.
Certificate of appreciation. Just before that, I would like to thank all 3 speakers who came today from very far, Polonnaruwa, Kandy, and Anuradhapura. So thank you very much for your commitment on behalf of CCP for being here, and also our help with the IT by the guest farmer being with us to help with the IT work here, as well as Nanila, who is handling the all presentation from his office to have it online. Okay, there's one more question just came in. Can we do gastric lavage if IV requirements are not available?
It's more risky. It's more risky. The patient is actually like putting an NG. There is no good evidence. Like NG, you think like I mean, is not so.
Okay, so we'll wind up session. I would like to hand over the certificate of appreciation to Dr. Dinamitra.